All right, then let's get started. Welcome, everyone. I'm Em. I'm one of the librarians here at Rockland Public Library, and we are so thrilled to be hosting tonight's program. I'm happy to turn it right over to tonight's speaker, Dr. Bea Szantyr, a fellow of the American Academy of Pediatrics and member of the American College of Physicians, has been board certified for both internal medicine and pediatrics. She came to Maine over 30 years ago in fulfillment of a National Health Service Corps commitment. Through her private medicine and pediatrics practice in Rowe, Maine, she has provided a broad range of clinical services in a variety of settings for people of all ages. Dr. Szantyr is an active member of Maine CDC's Vector-Borne Disease Work Group, as well as the International Lyme and Associated Disease Society. She is the medical advisor for MaineLyme, a Maine-based nonprofit formed in 2010 and dedicated to decreasing the occurrence of Lyme and related tick-borne diseases in Maine through awareness, prevention, education, and advocacy. And I'll turn it over to Bea. Go right ahead.
Thanks a lot, and welcome everybody. I look forward to seeing your faces. I look forward to getting back in person, but thanks for coming out tonight and for tuning in. I thought I knew Lyme disease, and yet more than, gosh, it's got to be over 25 years ago, I started on an odyssey of learning more deeply about it, and I was stunned to learn what I didn't know. So I'm going to try to share with you in an hour what it's taken me almost 3 decades to come to, and hopefully it won't feel like a drink from a fire hose. So I'm going to give you the spoiler. Prevention and early recognition of the disease are our level best approaches. Everything after that's doable, but it's harder. So here we go. Uh-oh. It's not working. Well, there, it'll work that way. It is rather hard to believe that a creature this tiny can cause so much trouble for so many people, and it's all over the world. And it does. The black-legged tick in the eastern US, Ixodes scapularis, or deer tick. In the western US, Ixodes pacificus, and it's got relatives around the world. I want to start by showing you this map, which I acknowledge is getting to be an old map, but I have a couple of reasons to show it to you. This is a map showing the US Lyme disease cases from 1990 to 2016. I want you to notice, first of all, that the color of no cases is white. Do you see any states that are white? No. So for a long time now, well before 2016, more like 1996, and certainly by 2006, there had been cases of Lyme disease reported from every state in the country. Now, although we think about it, or it's often talked about as having a geographic distribution, what I need you to know is that yes, there are hotspots in the Northeast, the upper Midwest, out in the West Coast in California, Texas, Florida, but the tick vector that transmits this disease has spread so that it covers much of the eastern half and much of the Midwestern country. The Western tick covers a good part of the Western country, so that although there are hotspots, this is a disease that has been reported from every state in the nation. I also want to bring your attention to Maine. In this 16-year period, Maine reported 12,472 cases. In the 5 years for which we have data since that time, there have been over 8,000 cases reported. So in about a third of the time, there's 3/4 as many cases. This is a big deal because the numbers are increasing. This graph shows the cases in Maine from 2005 out to 2021. Nobody's going to know what to do with these cases out here in 2020 and 2021 because of the impact of coronavirus and people's reluctance to show up for healthcare. So are the decreases because of that, or because there was generally a decrease in the number reported? We don't know. But the take home here is just the overall trajectory is upward. And if you look at it, between 2005 and 2019, we have about 10 times as many cases as we used to each year. And the other important piece about this information is every case that constitutes these bars is a case that meets the surveillance case definition, which is a narrow and rigid definition. And that makes sense because we need to know that every case that is counted as confirmed or probable actually is indeed Lyme disease. That's what it's used for. It's used to track trends. Federal CDC has acknowledged and done the studies that demonstrate that the true number of cases reported each year in the country is a lot more like 475,000, not 40,000. So for the state of Maine in 2019, did we have 2,000 cases or 10 times that number, 20,000? We don't know. Uh-oh, I'm stuck again. There. Okay. So when do you get Lyme disease? Right now. June, July, and August are the months that are the peak for acquiring Lyme disease or reported cases. And that makes sense because these are the months when the nymphal tick, stage of the tick, which is about the size of a poppy seed, is most active looking for its blood meals. It's easy to miss because it's so small, and we're engaging more deeply with nature in less clothes. So a lot of sense. September, October, November, the adult tick is seeking its blood meal. If it fails to get a meal in that time period, it winters over. And when temperatures come up above freezing, those ticks again begin their quest for a blood meal. In 2021 report, the tick lab started seeing adult ticks submitted to them for evaluation at the end of February, beginning of March. And so we see cases of Lyme disease rise there as well. But you've noticed that there are no months anymore during which Lyme disease is not reported. That's true nationally, and that's true here in Maine. It's an equal opportunity infector by age, so 0 to over 90, and pretty much by sex, a few more males and females, most places except in the older age groups. There are two age kind of predominances, so 5 to 14-year-olds and 45 to 64-year-olds. The interesting thing about Maine is we have been seeing this over 65 group actually outpace the 45 to 64-year-olds. So our hump looks a little bit different. And some years they've even outpaced the 5 to 14-year-olds. We do not have a good explanation for that yet. Oh no, so you can never go out again, right? But you live here. And if you live here, you live someplace that looks like this, nestled into lots of woods with lots of water around. You almost certainly recreate and work in places that look a lot like this, water, lovely woods. And I'm sure you've walked down a road that looks like this. And importantly, you've probably walked off this road. And if those things are true, you are at risk for Lyme disease. So what is it? Lyme disease is a multisystemic bacterial infection spread by an infected tick. The bacteria responsible is a spirochete or corkscrew-shaped bacteria called Borrelia burgdorferi. And in late infections and persistent infections, it might be more complex and multifactorial. So the bacterial cause, Borrelia burgdorferi, actually is a family of bacteria. Here they are. Everybody, did you have supper yet? Do you want to? I'm going to show you awful things. Anyway, a family of bacteria, a number of different ones are responsible for the disease in different parts of the country. In the US, it's predominantly Borrelia burgdorferi sensu stricto. I know you need to know this, and it'll be on the quiz at the end. There has also been a small number of cases caused by a relative called Borrelia mayonnaise. In Europe, there are 3 different agents of Lyme: Borrelia burgdorferi, sensu stricto, Borrelia afzelii, and Grignii. And around the world, there are different ages in different places. These are all zoonotic pathogens. And by zoonotic, what we mean is they are transmitted to humans by animals. Now, technically, zoonotic just means it's transmitted among species. But for our purposes tonight, it's particularly important that it's from animals to humans. Now think about it. What kind of incredible bacteria would you have to be able to survive in ticks, to be able to survive in rodents, to be able to survive in other mammals, to be able to survive in birds, to be able to survive in humans? That takes a lot of adaptation. And in fact, this is a very adaptable bacteria. Not surprisingly, it's very old. Ötzi, the Tyrolean Iceman, 5,300 years old, was found to have the DNA of this bacteria in his bones. So why is that important? It means that this bacteria has found ways to survive. How about the ticks? Well, let's look at them. They're integral to this whole process because they are the ones who acquire the infection from the rodent host. Predominantly white-footed mice serve as a great reservoir and then transmit the infection to humans and other animals. For the tick, they take one blood meal per life stage. Once infected, however, always infected. So it gets transmitted on to the next life stage. There are 15 species observed in Maine so far. Of those 15, probably the two that interact most with people are the black-legged tick, or Ixodes scapularis, and the dog tick, Dermacentor variabilis. So let's spend a little time on that, because I'd like you to be able to know how to identify them. The black-legged tick is small, very small. How small? Very small. This is the nymphal stage, the stage that's active now, about 1 millimeter, size of a poppy seed. This is the adult female, about 2 millimeters, size of maybe a sesame seed. But size can't be the only thing you use to identify these ticks, because here you can see the adult female, and right next to it is an engorged adult female. Once they start to feed, it can be difficult to identify them by size. So you have to know something more. No, you don't have to. Wait. These ticks are either uniformly dark or two-toned, kind of like that. Compared with the other common tick we encounter, which is the dog tick, which is a little larger, maybe apple seed sized rather than sesame seed sized. But look at these markings on the back, these lacy white markings on the shield of the female and these racing stripe white markings on the male. Those markings are still visible even when the tick is engorged. So when we look over here and see the engorged dog tick and the engorged deer tick, without them being side by side, you would not be able to tell. But I assure you, they keep those markings and so are identifiable. I wanted to tell you just about one other tick that is not well established yet in Maine, but is becoming established. It certainly has increased its range from the Middle Atlantic and the Midwest and South to New England. This is the Lone Star tick, Amblyoma americano. It is also a fairly small tick, not quite as small as the deer tick, uniformly dark, or it has this telltale white spot on it. The reason I tell you about this tick is twofold. It does carry infections, not Lyme disease, but a Lyme-like illness called STARI, or Southern Tick-Associated Rash Illness. It also has been an Ehrlichia disease, but it's also been associated with red meat allergy. Perhaps you've heard about that. I think it will be important for us to know so that if you have unusual, odd symptoms and have noticed a tick bite by this tick, or at least the folks in the area know that it's possible, perhaps we'll be able to make better diagnoses more quickly. So where do you encounter the black-legged tick, the deer tick? Brushy areas, especially the edge of the woods, as opposed to deep in the forest, moist leaf litter, tall grass, wood piles. Well, wood piles make sense. What's in wood piles? Rodents. And what's on rodents? Ticks. How does this happen, though? Well, these are the mouth parts of the nymphal tick, what we often call the head of the tick. is entirely an eating portion of the tick. It's an eating machine portion. So the tick attaches with its palps. It slices into the skin with these chelicerae. Then it inserts this barbed mouth part into the wound and feeds by sucking a little and spitting a little. It slices in, but you don't feel anything. How is that possible? Well, tick saliva. They are very small ticks, so it might be that you don't feel it immediately, but these ticks feed for several days. The nymphal tick plans to feed 3 to 5 days. The adult tick plans on a 7 to 10 day feed. Tick saliva has a numbing substance, so you don't feel an attached tick. It also has a cement-like substance. Why do you need to know that? Well, between the cement-like substance and those barbs, they're hard to pull out. So using fine tweezers as close to the skin as you can, steady, gentle pressure straight, and it comes out kind of hard. Important to know. I don't want you to give up that method. It also has blood thinners. It's a good animal trying to do a good job getting a blood meal. And finally, the immune suppressors. It has immune suppressors in order to prevent our bodies from reacting to that bite so that it can finish its meal. It's a good system for the tick. So what is Lyme disease? We often talk about it in stages. Early Lyme disease consists of a rash called Erythema migrans, plus or minus flu-like symptoms. Now, something that's gonna just hurt your feelings, the classic bullseye rash that you've heard about is not the most common rash of Lyme disease. The most common is a uniformly red, expanding rash. It might be warm or raised or itchy, but most of the time it has no symptoms at all. And about 30% of the time to 40% of the time, there is no rash. The rash, when it does appear, 3 to 30 days is the usual time frame, but it can be as short as 1 day or as long as months. There can sometimes be a rash at the site of the tick bite that's very small, maybe the size of your pinky fingernail. That's a reaction to the tick. It ought not to be an expanding rash. If it's expanding, we have to be concerned. And very few people who get Lyme disease actually remember seeing a tick. So fewer than 30%. Okay. So here it is. If I showed this first, everybody knows what we're talking about. There's that bullseye rash. But here's another look at a bullseye rash, and it is a little different. You see this kind of scabby area in the middle, and someone has drawn a line around it. Well, that's a good idea if you have a rash to draw a line and notice if it's expanding, which this one was. But here's the more common appearance of an Erythema migrans, rash of Lyme disease, uniformly red. Now it might have this little dot in the middle, what we call the punctum, where the tick was actually attached. But over here, I want to show you, this doesn't look round at all, does it? This is Erythema migrans. Every rash I'm going to show you has been documented to be. This does not have a round look. It's expanding. It's under a breast. When the rash expands, it expands along the planes of the tissue that it's in. So it might not have that round appearance. These are more rashes. You guys are going to be such pros. This is in a groin, and this is probably the second most common appearance, where you have a very dark center and a lighter outer rim. This one, you can see there's almost a bluish appearance in the center with these extensions going out. It looks a little ragged, and then you've got those sort of, I don't know, crab-like extensions. What the rash of Lyme disease represents is this bacteria moving through your skin and your body's reaction to it. Over here, you can see that these rashes can be huge. I gotta try and move this so I can see this part over here. You see, this is an armpit, and this is a rash taking up almost the entire flank. So that has gotten huge. And look at this blistered area in the middle. Kind of looks like shingles, but it doesn't hurt. So think Lyme. On darker skin, it can take on a different appearance, sometimes a bruised look, but even perhaps something that looks more like ringworm. Not ringworm because it doesn't have the flakiness and doesn't itch. Behind the knee is an important place to be looking for these ticks. It's not an uncommon place to have an erythema migrans. And look at this rash. I want to draw your attention to this. Look at that angry red, almost whole way around the shin. That looks like cellulitis, and it could be. What's important is that it's not just the rash, but the history and the possibility of an exposure that's going to be so important to figuring out what's going on. Now, I tell you specifically about this cellulitis idea because the most commonly used antibiotic to treat cellulitis won't treat Lyme. So you have to make sure your clinician knows that there's a possibility, and there are antibiotics we can use that will treat both. So does it have to be more than 5 centimeters? Well, to be part of that bar graph I showed you earlier, yes, it does. That's part of the surveillance definition. But for treatment purposes, it's the history and not necessarily the size. So here's a 2 centimeter rash about a day or so after a tick bite. This is the same rash the next day. You can see that it's taking on that bullseye appearance. Now, this is the same child years later. You do not get immunity to this one. You can get Lyme disease again and again. Oh my goodness. But how about these rashes? Very subtle, a blush on the belly, or this ring-like appearance, or even this one that looks kind of like a chafe from the waistband. Each of these is Lyme, each is Erythema migrans, but it sure would be easy to miss these rashes, especially if they had no symptoms, right? Well, when we look at national data, what we see in the clinical features of cases of confirmed Lyme is that about 1% have evidence for carditis. About 15% altogether present with some kind of neurologic condition, arthritis in almost 30%, and the rash in about 70%. So, okay, how about Maine? Do we look like that? Well, the rash, back in 2005, 74% of patients who presented with Lyme that was confirmed had a rash. But boy, not since then. Around 2015, a concerted effort was made to get the rashes reported because some of the thinking was, well, people just aren't reporting cases that are just the Lyme rash. But those numbers have not come above 50% in quite a long time. And look at last year now. We don't know what to make of 2020's data, but that's a pretty low number. What does this mean to you? Do you have to have a rash to have Lyme disease? No. Not everyone gets or remembers a rash. So what symptoms might you have? Well, you might have malaise, fatigue, lethargy, that I can't take another step feeling, or headache, fever and chills, stiff neck, achy joints, achy muscles, backache, lost appetite, sore throat, nausea, funny feelings in your skin or your extremities, vomiting, abdominal pain, more common in children than in adults, light sensitivity, stiff hands, dizzy, cough, chest pain, ear pain, diarrhea. It's a whole body experience. Do you have to have all of these symptoms? No, but you might have a few of them. So what do? Well, if you have a rash with or without flu-like symptoms, take a picture of it. Put a ruler in for size and draw a ring around it. Notice if it's expanding, changing. Try to remember what you've been doing, what your activities have been, and is it possible that you've had a tick exposure, and get to your healthcare provider. The rash of Lyme disease, that EM rash, is Lyme disease and needs a full 3-week course of antibiotics. Testing is not indicated at this point because don't make antibodies that are measurable for 2 to 6 weeks after infection. We don't want to wait that long to get you treated. So no testing is needed. The rash is the diagnosis. Well, what if you don't have a rash? What if you have flu-like symptoms without a rash? In high tick season, which we are in, well, consider that whether you've had an exposure. What have you been doing? See your physician. If the history and the possibility of a tick exposure support a diagnosis of Lyme disease, experts recommend treating just as if it is Lyme disease. Again, testing will not be helpful because you don't make antibodies that early. Well, what happens if we don't treat early? Well, the infection can disseminate. It can spread through the skin, like with multiple skin rashes. This is not several different ticks. This represents spread through the bloodstream. It can spread to the neurologic system and cause trouble with cranial nerves. This person has a facial nerve palsy. She's been asked to smile and close her eyes. The right side doesn't work, but it can involve other cranial nerves. Some folks have double vision or blurred vision or hoarseness or difficulty swallowing. It can cause pain in nerve roots, meningitis, inflammation and infection of the lining of the brain. Peripheral neuropathy can be a Lyme problem. Problems with thinking, mood, memory, including depression, anxiety, and even diagnoses like mania, bipolar, and psychosis. This is a big deal when it spreads, or can be. Parts of the heart, every part of the heart can be involved. What we hear most about are conduction system abnormalities called heart block, but every part of the heart can be affected in the lining of the heart, the inner lining of the heart, even the heart muscle itself. There have been deaths as a result of Lyme carditis. So consequential. If we don't treat early, approximately 60% of people go on to develop frank arthritis. That's swelling and inflammation of a joint. Often a knee, but not always. It can involve wrists, elbows, shoulders, hips, even the TMJ. So untreated, it can cause trouble. And every part of the eye can be affected, from the conjunctiva to the deep tissues of the eye with maybe iritis, even the optic nerve to the point of blindness. So we don't want to miss this. We want to treat this infection early. Symptoms tend to be variable. They come and go. Flu-like symptoms that are recurring, nobody gets the flu once a month. We really have to pay attention to this. And in late and untreated or persistent disease, symptoms tend to be in clusters rather than one single symptom. And that usually includes fatigue, something in the musculoskeletal system like achiness or frank arthritis, and neurologic types of symptoms. How do we make the diagnosis? From the history. We have to find out, how did this start? What are your symptoms? Do they change? And you have to realize that these symptoms may overlap with other conditions. So you want someone who's really paying attention and someone who's going to try to diagnose what's going on with you, not someone who's wearing blinders and can only see Lyme disease, or someone who wears blinders so that they never see Lyme disease. A careful physical exam, the findings in Lyme disease can be quite subtle. There are tests for tick-borne diseases, and when they're indicated, we should do them. Tests for other illnesses to rule them out. And finally, we look at the response to treatment. Of course, there are challenges. Laboratory testing is one of them. We do not currently have a laboratory test accurate enough to definitively rule in or rule out Lyme disease. What we use most commonly are antibody tests, serology. Now, they can have false positives and false negatives. I'm a simple thinker. I worry a lot about those false negatives, and they're more abundant than false positives. But early in disease, they're not useful. It takes 2 to 6 weeks after infection to develop a measurable antibody response, if you develop one. In late disease, they're better for arthritis, about 97% sensitivity, meaning they can pick up about 97% of cases of arthritis. But for neurologic disease, they miss about 30%. So 70% sensitivity. And in persistent disease, so if you have infection, are treated, and then continue to have symptoms, they are very difficult to interpret because the antibodies can stick around or they can disappear. And it's not related to whether you're well or ill. So the tests can be supportive. In the vaccine trials done years ago, they found that if they relied solely on the antibody testing to make the diagnosis, they would have missed more than a third of the patients. And it's not just Lyme disease. There are other infections carried by the same ticks. I just wanted to show you that the numbers in all of them seem to be increasing. Anaplasma is a white blood cell infector with some similar symptoms to Lyme disease. Babesiosis is a red blood cell infector, a relative of malaria. Again, all of these have some similarities in their symptom profile. They are both carried by and transmitted by the black-legged tick, the deer tick. Powassan virus, we're going to skip that one for a minute. Powassan virus, you may have heard about this. It's become part of the news more recently. It's been around for a fairly long time. We in Maine are seeing pretty regularly 1 to 3 cases a year. The problem about Powassan virus is it's a severe neurologic infection, or can be, and we have no treatment for it. So all we can do is support a person and wait for them to recover if they're going to recover. We've had in 2013 a fatal case of Powassan. Already in 2022, there have been 2 fatal cases of Powassan virus as of February. Both were in individuals who had immune compromise. I don't know if that was a huge influence in it, but that's how it was. Powassan virus, unlike these other 2, which can be transmitted in hours to days, can be transmitted in minutes. 15 minutes of tick attachment can result in a Powassan infection. So if nothing else I tell you about tonight gives you the idea that you should keep ticks off of you, I hope that at least this piece of information will. Now, this Ehrlichia chaffiensis I included, it is not transmitted by the same tick. It's actually transmitted by that Lone Star tick, the single white dot tick. But I put it on here mostly because over the years, we seem to see sort of not a definite trend, but a suggestion that the cases are increasing. And again, not just this Ehrlichia, also Starry, and also red meat allergy. Okay, so the diagnosis. If you have the rash of Lyme disease, you have Lyme disease, you need full treatment. If you have a history, a physical exam, and lab data that supports Lyme disease, it's probably Lyme disease. You need full treatment. Here's where it gets complicated. When it's uncertain, when it's complex, if you fail treatment, you treat but you don't really recover, then you have to consider, in addition to Lyme disease, other possibilities, including the other tick-borne infections, some other rheumatologic diseases, fibromyalgia and chronic fatigue, which are technically syndromes and we don't understand what the cause is. So they can be caused by some things. Problems in the endocrine system, infections that have nothing to do with the tick, other diagnoses. You want someone who will look at you. Remember, the goal is not to diagnose your Lyme disease. The goal is to diagnose what's wrong. How do we treat? Antibiotics, antibiotics, antibiotics. But challenges even here. Which ones? There are failures documented for every regimen. And people are different. So what works for one individual may not work for another. So you have to be watching and willing to make changes. There's very little research that has been done on combinations of antibiotics. And there's some suggestion that combinations are going to be a very good idea, particularly in late or persistent cases of Lyme. And how long do we treat? That's actually not been well established, and it varies by the stage of the disease. Longer for later disease than early disease. There are conflicting recommendations that are handed down, and often the recommendations in guidelines are based on population studies, so we get averages. Well, no individual person is necessarily the average. We need providers who will take that information and then apply it to each individual person. And so we have to consider the complications and the effects of treatment, but also the consequences of not treating. So are there things that can help us to make those decisions? Are there things that can help guide it? Well, in fact, there are. First, we have to decide what we're going to focus on. We're going to plan on patient-centered outcomes. So we want you to get back to your pre-illness wellness. Looking at early cases, early trials, early studies of Lyme and treatment of early disease, 3 weeks of antibiotics were effective in over 75% of patients. And importantly, 10 days was not as effective. The other thing that happened in those early studies, if an individual failed treatment, they were immediately retreated and successfully. Looking at bench research in the lab, they looked to try and figure out, is it how long the bacteria is exposed to the antibiotic, or how much, what concentration of antibiotic was effective. And it turns out that how long may be more important than how high the concentration. And in those studies, we also found that there were some things that could predict a need for that longer treatment. Individuals who were very ill at the time of diagnosis, who had neurologic symptoms, or who had multiple EM rashes. Now, all of that is consistent with a disseminated, a spread infection. It makes sense that they might need longer treatment for recovery. And this other one, which I think is sort of obvious, individuals who are still symptomatic when they finished the antibiotic. So you need follow-up. So here's a guide. And this is a guide presented as a starting place. This is where we start. Our goal is to avoid the late complications safely. So for the rash of Lyme disease, certainly 3 weeks and maybe 4 to 6 weeks of an antibiotic. Start, a place to start. For disseminated infection, for multiple rashes, or for carditis or meningitis, 4 weeks or longer makes sense. For latent persistent disease, probably it makes a lot of sense. We know from arthritis studies that it does, to start with 4 weeks or longer. Repeat it if you're not recovered. And maybe at that point, you need to find someone who's well acquainted with it. Antibiotic combinations might be more effective, and making sure we identify and treat any co-infections, particularly when we're dealing with individuals who don't recover or whose symptoms suggest they might have co-infections. The key on all of this page, the thing I want you to remember, is that follow-up is necessary. This is not a grab a prescription, see you next year, doc. This is let's follow up and make sure that you are well when treatment is finished. Every patient needs individualized care. And that takes us to the prevention part. So wait, the ticks. We forgot the ticks. This primordial type of prevention would have been ideal. But of course, the ticks sailed on that ship. So we are left with figuring out how people can do prevention. It's a pyramid. I like to think of it that way. The base is avoiding tick bites. You can't get Lyme. Mostly you can't get Lyme if you don't have tick bites. We know that there is transplacental transmission. That is, it can be transmitted in utero. But for most of the population, the primary method is tick bite. Prompt removal is the next level if we don't keep it from attaching. And some number of individuals ought to get an antibiotic to prevent the development of Lyme. So how do you keep from having ticks attached to you? Well, avoid tick-infested areas if you can. Be aware of the environment you're going into. Know if it's likely to have ticks. Wear light-colored clothes. They're dark-colored ticks. You might be able to identify them outside. Tuck your shirt into your pants into your socks, and get that ever so slightly nerdy look that the game wardens have really made sporty. That creates a barrier from the ground to your wrist. Check for ticks outside and after you come in. Permethrin, used on clothing and gear, is fabulous. It works to prevent tick attachments. If you do your own clothing, you need to do it in a well-ventilated space because breathing permethrin is a relatively toxic thing to do. Once it dries into the clothes, so you spray them to damp, let it dry in, it will last for several washes and several weeks. And permethrin has been shown to decrease tick attachments. It's toxic for ticks. Now, it's also toxic for cats while it's wet. So don't allow your cat to be part of your treatment plan. But it's summer, you're going to tell me. I don't want to wear all that clothing. Well, the good news is the University of Rhode Island did a lovely study and showed that even if you just spray your sneakers and your socks, you can decrease the number of tick attachments 73 times. That's pretty impressive. Now, I'd still prefer you wear those long pants and do the tucking, but there's hope. On skin, you've got to use a repellent. I recommend that you use an EPA registered repellent, DEET, 23 to 50%. More than that, not more effective. Less than that, not effective. It's the gold standard, at least 70 or so years of safety and efficacy material. The key to using DEET safely is don't put it on the backs of children's hands and wash it off at the end of the adventure. The problems that have ever shown up with DEET have been from repeated high dose applications over an extended period of time without washing it off. Simple thinker, wash it off. IR 3535 used to be only in Avon Skin So Soft Bug Guard Expedition formula. No longer is that the case. Cutters has some and other manufacturers. It needs to be at least 15%. Most of the stuff I've seen recently is 20%. Its claim to fame is you don't have to wash it off in between. Again, simple thinker. It's a chemical. Wash it off. Picaridin, 20% as effective as DEET in the studies, and some even more effective. Seems like it is better tolerated by individuals who have chemical sensitivities. Effective, again, wash it off. And finally, PMD, oil of lemon eucalyptus, 20 to 30%. There's a great web page. The EPA has a repellent page where you can kind of type in the repellent you might want to use, how long you plan to be out, and they can give you some guidance on repellents that have safety and efficacy. When you finish your adventure, come in, take your clothes off, throw them in the dryer on high heat for 6 minutes. That kills ticks. If you have to wash your clothes first, then they need to be in the dryer for more than 50 minutes. The wash will not kill it. Water is not the problem. High heat dries them out. That will kill them. And if you can take a shower within 2 hours of outdoor activity, that has been shown to decrease tick attachments in Lyme disease. Now, I think part of it is that you wash off ticks that are just walking around and not yet attached. The other part is if you do a thorough wash, you are looking and feeling all over for those ticks. You might feel a bump. Remember to check the hot spots behind the knees and the groin, at the waistband, under the breast, the armpits, behind the ears, the scalp, the belly button. Okay. And remember that you have to check your companion animals. They can get Lyme too. And if they have been protected with some of the agents now that keep ticks from actually attaching, they can bring ticks into you. So for dogs, particularly the snout, the ears, in the armpits or the groin area, but also along their sides and their pads. Property management. You can decrease tick abundance in your yard. Reduce tick-friendly habitat. Get the brush and leaf litter away from the active areas of your yard, wood piles, rock walls, and yes, I'm sorry, bird feeders. Birds are mass transit for ticks. When we look at the spread of Lyme disease, you can see a real relationship along bird flyways. Kirby Stafford from the Connecticut Agricultural Experiment Station has said that we are probably quite safe to feed ticks from October to April because they are not parasitized by the adult stage of the tick, but rather by the nymphal tick. And you can see around this bird's eye and by its mouth, there are several ticks attached. So it's the larval and nymphal ticks that are more likely. If you do feed birds, feed them away from the active places in your yard and be aware that you're doing it. You're also attracting rodents, and need I say more? Ground covers that harbor ticks are things like Japanese barberry, um, pachysandra, things that tend to be in levels that keep moisture and make good hideouts for rodents. So remove it. Tick unfriendly yardscape basically just means drying it out, and that's keep the lawn mown short. That lawn that is dried out and kind of brown and yellow looking, yeah, that's the one for me. A border of gravel mulch or wood chips about 3 feet around the yard, it does not prevent ticks from being in your yard, but ticks are only going to move a certain distance from that brushy area at the edge. So you might decrease how far into your yard they penetrate in that way. If you decide to spray, I recommend getting a professional, licensed, reputable sprayer so that they can do it right. There are things we can do that can help decrease the ticks on our property. I should tell you, though, that none of the studies have shown that decreasing the number of ticks has been related to decreasing the Lyme disease. And part of that may be that we don't just live on our property. And if all of our neighbors aren't doing it, it may not be as effective. Deer resistant planting, deer fences actually do work to keep deer out. And rodent control using rodent bait boxes can be effective. You've heard about perhaps those rodent tubes can be effective, but you have to keep up with them and be very consistent in making them happen. There was an integrated pest management way that was demonstrated to be quite effective using a naturally occurring soil fungus, Metarhizium anisopale, and in combination with rodent bait boxes, and was very effective at reducing ticks and kept them reduced. So there are things you can do for your property. That's just a look at what the well-preserved property might be. I do want to just show you the swing set thing. Remember, I know you want it in the shade to protect your children, but it really needs to be in the dry area of the yard so that they're not exposed to ticks. Well, you did the best you could, but you got a tick bite anyways. Now what? Prompt, proper removal. Find tweezers as close to the skin as you can, steady, gentle pressure, or use a tick scoop. Get the V-notch around that tick and move across the skin. Never annoy the tick. When the tick first starts to feed, that bacteria is in its midgut most of the time. If you annoy the tick, it is possible that it could regurgitate that bacteria and turn what might have been a short duration attachment into a guilty one. So no heat, no chemicals. Try not to break the tick open. Wash your hands, wash the site, wash your tweezers, and save that tick, at least for identification and maybe for testing. What we know is disease transmission of Lyme disease over time increases. So the more time, the more it increases. So when we're trying to estimate the risk of a particular bite, what we're really kind of trying to look at is the infection rate times the amount of time that the tick was attached, and trying to determine if this now is a bite to be worried about. That can be challenging because tick infection rates can be variable across different geographic areas. Overall, in the state, I think we are talking about a nearly 50% infection rate, so something to consider. But that can vary from mile to mile. So what you need to do is identify your specific risk from this bite. And are there things we can use? Well, in fact, there are. The level of engorgement. Can you see any evidence of feeding? Is that tick flat, or has it begun to swell a little? Now, you may not be expert at that, and your physician or healthcare provider may not be expert at it. But if it's not flat, then there is evidence of feeding. Attachment time. Although people tend to be very bad guessers at this, like how long the tick has been attached, it turns out that if one thinks it has been attached for a long time, say 3 days or more, that's likely to be a higher risk bite. So Now, PCR positivity. Now, PCR is a DNA test for the DNA of the bacteria that causes infection. When it's positive, it is a good predictor of the tick's ability to transmit infection, because obviously if it's not there, it's less likely. But we never have that piece of information in time, because if you're going to start an antibiotic to prevent Lyme disease, it has to be done within 48 to 72 hours of that tick attachment. And the turnaround time for the testing is just generally longer than that. And finally, was the removal complicated? That's something you can know at the time. Did the tick break? If the tick breaks, then tick fluids may have gotten into the wound from the bite, and that can make it a more risky bite. The risks of treatment, yeah, you react to the antibiotic. What if you have multiple bites in a season? Besides indicating that I didn't do a good enough job tonight telling you how to prevent that, that puts you at a lot of risk from a lot of antibiotic. How about we treat an uninfected bite? That could happen. And of course, it costs something. But there are risks to not treating. So Lyme disease that was preventable, maybe some other infection that was responsive to doxycycline. As I say, we have absolutely no studies to tell us about preventing these other infections. And of course, the cost once you have not been treated but developed disease. So if we decide you have a high risk bite and we should treat with antibiotics, or we should treat, best option, doxycycline for 10 to 20 days. There are no specific studies that inform us precisely what to do on this. So this is synthesized from a number of different perspectives. Other options are less useful. And I know you're hearing me say 10 to 20 days, and I already said, well, we're going to treat early Lyme disease for at least 3 weeks. So this is looking pretty close, but 10 days is not 3 weeks, right? Doxycycline as a single dose is often prescribed. It's based on one single US study. And in that study, they used as a marker the development of rash at the site of the bite, and they only followed people for 6 weeks. So we know that not everyone gets a rash, and we know that 6 weeks isn't long enough to see the late complications. So not an ideal study. In addition, there were cases that they didn't count because of the way they defined it. So although it reported 87% efficacy, reanalysis really suggests that it couldn't be more than 50%. The bottom line is we don't know. We don't know exactly the right thing. But if we treat early with an amount of antibiotic that doesn't clear the infection, we can turn off the immune system response, so turn off your antibody production without fixing the disease. Now, 6 weeks later, you show up sick, your tests are negative. Unless your provider really understands that you might still have it, that could be a bad situation to be in. Well, how about watch and wait and see? Let's not treat. Yeah, it's a risky bite, but let's not treat. Well, there are circumstances in which this might make sense, right? If it's a very short duration attachment, if it's a less than 12-hour kind of attachment, the tick is flat, the removal was very straightforward, the tick is intact, you could consider it. But what are you waiting to see? Remember, 30% of people may not have a rash, at least 30%. You're waiting for the first symptom. So if that's the decision you make, that first symptom should get your doctor to start the treatment, and it would be full treatment for Lyme, okay? Regardless of the choice you make, to watch for about treating with antibiotics, you have to watch for rashes and flu-like symptoms for at least a month. Mark it on your calendar. Pay attention to that. Even if we treat, it is still possible that you would develop Lyme disease. Okay? Well, there you go again. Every time I want to talk, you go and bury your head. Please don't on this one. This is a potentially preventable bacterial infection that, if we miss it, can be quite devastating for people and difficult to treat. Our level best opportunity is to prevent tick attachments. Second best is to identify and treat early. Everything after that, we can do, but it's hard. All these folks contributed to this slide presentation, and I am grateful. And I want to thank you, Em, and the Rockland Library for having me, patients and families who shared their experiences with me, and of course you for paying attention to this tonight to try to prevent Lyme disease. An ounce of prevention genuinely is worth a pound of cure. And that's all I got.
Thank you. Excellent. And do we have any questions either in the chat, or you're also welcome to unmute yourself and ask her directly? Oh yes, you can. If you have any questions, you can ask her directly, or you can ask me. And I can.
Yeah, I'll tell you what I did. I took strips of cotton muslin about 2 inches. I sprayed them with 100% DEET.
Okay.
I wrapped them around my wrists. I put one around my neck and let it hang there, one around my waist. And I had on 3 pairs of socks. I tucked my pant legs in. I cut off a pair of socks to make like gaiters around the pant leg and the inner sock. And I dusted that with Gold Bond powder, because I had a hiking backpacking instructor who said that Gold Bond can repel the DEETs. So I'm curious about if you thought maybe I did enough. And what I did was I had the strips of fabric. I put on one shirt. I put the fabric around the wrist. Then I put another shirt on over that.
This sounds like an aggressive approach, but let me just offer some thoughts on it. That's hard to maintain every time you go out into your yard. And, you know, the University of Maine's report, which you can get on their website, their tick lab report, showed that about 65% of people are picking up Lyme in their yards. Or the ticks, well, not picking up Lyme, let me rephrase. The ticks that they're receiving are from people who pick them up in their yards. So not quite the same thing. But my concerns, we know that permethrin works, and you can, you know, you can spray your own clothes or get treated clothing and have it effective. They also have gaiters that you can put on quickly. So those sorts of things. The way that DEET works, while it does have some effect if it's on fabric, the way that repellents generally work is with your body heat and body oils to create a vapor layer around your skin. So you may get some effect from spraying cloth, but you would have likely better impact from letting it work the way it's sort of intended with your skin. I can't speak to the Gold Bond at all, but that would be an interesting thing to know about. So I think you're working really hard to do this protection, and as long as you're doing serious tick checks at the end, I hope you will be successful. But you might want to consider permethrin treated clothes, because we have good data to say that that really does help.
Yeah, and that's a spray.
It comes as a spray. It comes unscented, which is handy. And the spray, you know, you can, I think Dick's Sport carries it. I think Walmart often carries it. I know you can get it online through Amazon and such places. And none of these people are giving me any kind of, you know, premium for mentioning them. These are just places that I've seen it. And so, and it comes in get a pretty good jug, because you may need to use more than one application per season. Several weeks is not the whole summer, and tick season really is spring through fall with a little bit of winter. So you want to make sure you have enough, and spray it into the fabric till it's damp, wet. Hang it out, let it dry, and then it's good to go and will be good for several weeks.
And can you buy like a bottle of liquid permethrin and dump it in the container?
You can, but let me tell you my problem with that. Now you're left at the end with the leftover permethrin. How will you be disposing of that?
Oh, okay.
You know,
Yeah.
so you can. I would do that only if I had a lot of stuff to treat so that I used it up.
Oh, I see. Yeah.
You know, yeah.
What about hummingbirds? Do hummingbirds carry ticks?
You know, that's a really good question that I tried to find the answer to. And I'm thinking they are unlikely tick carriers, but I don't know that to be true. And I say that mostly because they don't land on the ground much. You know, it tends to be the birds that are ground feeders or ground nesters. Lots of passerine birds have been shown to have ticks on them. Some of them even have been shown to carry the bacteria that causes Lyme disease, so they can become infected. Hummingbirds, I think, are low risk. I just don't think their behavior leads them to that.
My sister has bird feeders and a hummingbird feeder really close to her bay window, which is close to the front door. And of course, there's grass all around. And now, about a month or so ago, we were inside her house with the glass doors and windows low to the ground. And my sister said, "Oh, there's a chipmunk." I said, "No, that's a rat." And so she's got chipmunks, mice, now rats, and she lives right next to Chickawaukee Lake. So, you know, I'm like, oh my God. And she did have anaplasmosis a couple years ago.
Yeah.
And I was wondering, is it possible that something can go airborne and you can breathe in something?
Great question. To my knowledge, doesn't look like that's the transmission route. It really looks like it's tick feeding. So they acquire the infection and then transmit in their saliva, and it gets into your tissues and your blood. Anaplasmosis was probably almost 100% a deer tick. I mean, you know, nobody says absolutely about anything, but that is its transmission route. And that can be a very serious infection. In fact, when I am educating healthcare providers, and so you might as well know this too, if you even suspect it's anaplasmosis, do not wait for a lab test to confirm it, treat it. It can be so severe that it can be fatal. So not that Lyme can't, but it's less common. Lyme is more morbid than fatal, although there are fatal cases. And, you know, there are a number of situations where I worry more than I used to. There was a really good study about children with meningitis. So children with Lyme meningitis were more likely to have cardiac abnormalities as well. So it just, you know, we don't look all the time at electrocardiograms on people that come in with the rash of Lyme disease, nor probably should we. But I think we don't know necessarily how often it may actually be affecting the heart. So all of this stuff, what a mess, you know?
Yeah. So my sister had some kind of symptoms that did.
Hi. Oh, sorry. Can I ask a question?
Yes, absolutely. Go for it.
Thank you. Hi, Bea.
Hi, Ron.
Hi, Ron. You said something about preventative 10 to 20 days. That's kind of a new thought for me. Understanding treating, you know, right away if one has some symptoms, but are the 3 weeks to 4 or 5? Can you talk more about the idea of preventive antibiotic use?
The prevention, right, and you really have to distinguish between prevention and treatment, because once there are symptoms, we're talking about treatment, and treatment is a minimum of 3 weeks, depending on what symptoms we're talking about and what stage of the disease we're at, right? But for prevention purposes, for tick bite, just simple tick bite, and you've assessed that it's a high risk bite, antibiotic prevention, in my opinion, ought to be at least 10 to 20 days of an antibiotic. Specifically, I would use doxycycline. The earliest studies looking at can we prevent Lyme after tick bite didn't reach statistical significance, but that was because there weren't enough cases even in the placebo groups. And at that time, the infection rate among ticks was probably something more like maximally 20%. You know, all of these were done in the late 90s or in 2000. I would love to see testing or that kind of work done now with the higher infection rates and with a few different timing ideas, like what about 3 days? What about 5 days? What about 7 days? What about 10 days? What about 15? What about 20? Because nobody really wants to prescribe 20 days of an antibiotic, but that's based on mouse studies. And at least in mice, it looks like 20 days of an antibiotic prevents the development of complications of Lyme disease. It prevents Lyme disease development, whereas the single dose failed to do that. Also in that mouse studies, it prevented the development of anaplasmosis. So in ticks that had both infections, it was 20 days was effective treatment, whereas the single dose was grossly ineffective in preventing it. But those are mice. So, you know, we have to wonder, does that tell us about humans? And not exactly. So we don't have that answer. I just am very concerned when individuals are prescribed a single dose of doxycycline for a tick bite with no planned follow-up. And I worry that people are unaware that of the limitations of the studies that have fed that practice.
Okay.
So how's that?
Thank you.
Yeah.
Can you say a bit more about on the you said 20% in the 1990s, 20% of the tick bites were shown to correlate to Lyme disease, but now more like 50%. Is that what you were saying?
I'm sorry. I think I might.
I can repeat that a little bit. So you said back in the 1990s, about 20% of tick bites were positive for Lyme disease, and now about 50% are positive. What was the last bit?
Well, not exactly.
Can you clarify a bit more about that?
Yeah. Back in the 90s, when they were doing these studies, about 20% of the tick population who that had bitten the individuals in the study, only about 20% of the ticks were carrying the bacteria. The actual percentage of people who became infected was about 3%. And this is so something like that. And at least in Maine right now, for adult ticks, this past year, I believe it was almost 48% of the ticks were carrying Borrelia burgdorferi, the agent of Lyme disease. And more than 50% of all of the ticks had some infectious agent that they could transmit. I think those are huge numbers. And I think generally the infection rate among ticks is higher now. So can't say what percentage of tick bites really leads to Lyme now, because I haven't seen data that tells us that. There was a study done way back when, about the same time, that looked at when is it cost effective to treat a tick bite to prevent infection. And interestingly, it was when the possibility of developing Lyme disease was about 3.1%. So, and what they were talking about was not a single dose of doxycycline. They felt it was cost effective for 2 weeks of an antibiotic. That they took that number out of their hat, but that was what they were using in their calculation. So I don't know.
Could you repeat that about when it became cost effective? Could you repeat?
Can you repeat that about when it became cost effective, that last bit?
When the risk of Lyme disease, and you can assess risk looking at the infection rate of ticks, duration of attachment, however we assess the risk of the infection. When that reached about 3.1%, it was deemed cost effective to treat with 14 days of an antibiotic. The problem with that whole assessment was this was done by number crunchers who did not really look at whether 14 days of an antibiotic had a role. They just used that number, so that we are still left without an answer to how much do you need that early, within 48 hours of a tick attachment. How much do you need to prevent Lyme disease? We don't know. That's still a question that without an answer. So
one other question: if someone might have been exposed to, might have been bitten by a tick like a year ago, is there any, and therefore might have Lyme disease somehow in their, or one of these ailments somewhere in their system? Did I understand correctly that the diagnosis is still, sort of doing a blood test like a COVID test? Is there anything analogous for tick-borne diseases of that kind of, having a test that's then they can show you've got this ailment?
I love your question. The 2 points I'll make. One is, yes, we do know that there can be latency before you develop infection. That was well demonstrated in some neurologic studies. The challenge always with a latent infection is timing. You know about the tick bite that happened a year ago, but could you have had in between at some point before you develop symptoms another tick bite? So a challenge to know whether we can really attribute a disease that develops a year later to the original tick bite. Most people who get Lyme disease never see the tick. That's just true. As to the testing, if the testing were good enough, it might be very interesting to see if you had, positive antibodies directed against this bacteria, because, what it tells us not is whether you have disease, but that you have been exposed. So the difference between just exposed and having disease is symptoms, right? If you have no symptoms, are perfectly well, then we're not going to diagnose you with a disease by and large, in certainly not in this infectious disease area of Lyme disease. The other hard part about that is, even if we had testing that was sufficiently accurate, that we could identify it, to do a test for someone who has not got active symptoms now sets us up to have someone with a positive test, no symptoms. How do we know when to stop treating? By and large, we have to use the clinical elements of someone's history, their symptoms, their persisting signs, to make those judgments about whether treatment is done and has accomplished what it needs to. So that if you don't have symptoms, I don't have markers to guide that treatment. Does that make some sense? And we don't have good enough tests of any sort. There are a number of different tests being worked on. Some of them are protein tests, the antigens. Some are reactive proteins that the body makes in response to infections. I mean, there's a lot of work being done, but we don't have anything yet. What we have are largely antibodies. We would love for culture or PCR, DNA testing, or other direct tests of the infection rather than the body's response to it to be available and usable. But it's a slow growing organism. So culture is challenging, even if you could get it done. Most places don't do it. It's fastidious. It requires special medium. So that's a challenge. It doesn't spend a long time in the blood. This Lyme disease specifically is a disease of the tissues. It gets into the tissues. So it's very hard to get it in blood. You know, if you do a PCR in the blood and it's positive and you're sure your lab is reliable, so we're not seeing some contamination. If you do it and it's positive in the blood, that is really good evidence that the bacteria is there. But it's rarely positive. It is just the sensitivity of that test is very low. The specificity, if you find it, it's real. That's pretty high. And the PCR has been most useful on rashes. So on Erythema migrans, if you get a bite of skin and send it for PCR, it's really a pretty good test for that. But if you've got the rash, you don't really need that. So complicated, longing for better tests.
I'm going to pull actually a couple questions from chat because I don't want to ignore them as well. And their last couple of minutes, Ernie and Cindy had two questions. Their first one, can livestock catch Lyme? And if so, does it pass on to its meat? And the second question of theirs is, what is the update on a possible Lyme vaccine for humans?
Boy, great questions. Livestock, that's a great question. You know, there are some really interesting diseases, tick-borne diseases that livestock can get. Horses can definitely get Lyme disease. We don't eat them usually, but they can definitely get Lyme disease. Personality changes or other sorts of symptoms like that can be an indication. People who ride horses are at a little higher risk of Lyme disease, perhaps because of the places they go. Cows can get Lyme disease. I am not aware of it being in the meat. And it has not seemed to be a huge problem. I just remember some experiments that were done many years ago. And what I remember about them, so this is a little unfair, is the presence of the bacteria in cow urine. There's a treat. But I don't think it's common for cows. I should learn more about that. I don't know. You know, deer do not actually get Lyme disease, though they are hosts to those ticks, and deer meat is not a risk for acquiring Lyme disease. There are a lot of other reasons to cook it thoroughly, but that bacteria is probably not one of them. So I'm not sure if that helps, but it's always hard to know because deer are so involved in the whole life cycle thing that they're, you know, that's like mice. Mice generally don't get sick, even though the white-footed mouse keeps infection going pretty much all the time. Once it's infected, it's got infection in its blood, but it doesn't get sick. So you didn't ask that, but the vaccine question is a great question. There is about to be, and I believe Northern Light all over the state is going to be participating in it, a new vaccine trial. The first vaccine trial, Maine was a participant, and the new vaccine is also going to be tried there. I don't know the details of how they're going to be doing that trial. I know that the original vaccine problems were identified as being related to a portion of the gene that codes for outer surface protein A. They have eliminated the problematic portion, but this is still an outer surface protein A vaccine. So the good news is the way it works is hopefully by keeping a high enough level of antibody going inside the person so that when the tick feeds, that antibody gets taken up and you actually kill the bacteria inside the tick. Sounds good? What sounds better to me is the kind of vaccine we've developed for dogs, which includes outer surface protein A and C. A is in the tick, C is in the dog, so that if you keep high levels of antibodies, the likelihood of eliminating the bacteria goes way up. So we'll see what turns up. Do you want to know what I want for a vaccine? And they're actually working on this. Wanted this for years and it's no longer a pipe dream. I would like a vaccine directed against tick saliva. And the reason for that is there are so many infectors, and there may be more over the years. I have no reason to think we have now identified all that we can possibly have. I don't want people to let down their guard doing the personal protective things because they believe they are protected against Lyme disease. It's not the only infector. And so I'd like to see tick saliva so that the tick never attaches. That's what I want to see. I can hope.
It would be nice.
Yeah.
It's getting a little late, so I think I'm gonna have to call it despite the many questions that are still coming through,
Sorry.
unfortunately. But thank you so much to Dr. Szantyr for such a wonderful talk. This was really fascinating, and I feel like everyone really learned a lot. And thank you so much to everyone else for joining as well. This was really fascinating. And thank you all for your excellent questions. And I'm sorry we didn't get to them all.
Thank you, Em. Thanks, everybody.
Thank you.
Have a good night.
Good night.